With Straightsmile Solutions, straightsmilesolutions.com, and today we're going to go over a little bit more about phase one braces, what to do when, how it works, power chaining, things like that. And I do have a lot of other videos you should watch first before listening to this video because it's going to build on the principles that you learned in the other videos. So before you watch this video completely, I would actually like you to go to my YouTube channel. To access my YouTube channel, go to your YouTube channel, put in the search bar at the top on YouTube, Straightsmile Solutions. From there, that'll take you to my YouTube channel, which has a green banner. If you scroll down, you're going to see a playlist called Straight Wire. You're also going to see a playlist called Phase 1 Interceptive. Make sure you click around within those playlists and watch the related videos, especially on wire sequence and power chaining and Phase 1 braces. Okay, assuming you have watched those, then we're going to move on. This is going to be a little bit more of an advanced video. So just a friendly reminder, what is Phase 1 treatment? Phase 1 treatment is when you take a harder orthodontics case and you break it up into two chunks. The first chunk is done sometime between the ages of 6 and 9, sometimes 6 and 10, could be 5 and 10, and that involves fixing the bite. So whether you have transverse issues like a posterior crossbite, whether you have AP issues like an anterior crossbite, or a class 2 div 1, class 2 div 2, class 3, negative overjet, underbite, whatever you want to call it, whether you have vertical issues like a deep bite or an anterior open bite or habits, those are corrected in phase 1. The other thing that is corrected is that jaws that are constricted or too narrow are made the right size, so that hopefully the goal is if you set the foundation and the scaffolding and the teeth may and usually do come up straight. And we can go into the whole functional matrix theory and how, there's a reason why crowding is more severe now than it was 100 years ago and all that stuff, and it's more of a first world epidemic, but we won't get into that. But if you make the jaws the right size and the right position, teeth tend to come in straight and bites tend to be good, and often you don't even need a phase 2. I'm not going to promise, we're only going to lightly dangle that, but need would be in air quotes is the way I like to explain it. Phase 2 should at that point be a very, very easy breezy fine-tuning, maybe some short-term express aligners or a few braces for just a short period of time. It won't be anything major, hopefully. I mean, we can't fully control it, right? All we can do is build the scaffolding, put the foundation on, make everything the right bite and the right size, and hopefully the teeth will come in. Keep in mind that phase 1 is just the front 8 teeth, okay? So it's gonna be just these guys, just these 8 teeth, and the 4 molars in the back. If it's permanent teeth, that's what we do in phase 1. So 7 through 10, 22 through 26, or 2 to 2, 2 to 2, whatever you want to call this. 1, 1 to 2, 2 to 3, 2. Sorry. 1, 2 to 2, 2 to 3, 2 to 4, 2. This group and the 6s. Okay, that's what phase 1 is. That's it. We're not waiting for the other 12 teeth to come in. Yes, we've got the 3s and the 4s and the 5s on all these quads. That's part of phase 2. This is phase 1, okay? Getting the bite correct. And as needed, making the front teeth straight if that's part of interceptive treatment. Now, of course, if we're looking in the pattern and we're seeing impacted potential canines, yes, then I'm going to straighten these teeth because I want to give these canines as much space as possible to drop down and get the roots out of the way. That would be interceptive because it's a health problem. Now, if it's just like tiny bit of crowding on the lower incisor and it has nothing to do with health issues, I'm probably not going to straighten it, or I might. It's really up to what you've talked to the parents about. So for some parents, phase 1 is just aesthetic, but for me, phase 1 is functional and aesthetic. So at the end, it should look like this, okay? Nice bite, nice overjet, overbite, no transverse issues, no AP issues, no vertical issues, okay? That's phase 1 completion. Then you may or may not put the patient in retainers. There's all different types of phase 1 retainers we can use. Sometimes we don't because you're going to possibly have a phase 2 anyways. Maybe we'll put in a lingual arch, a TPA, a Nance. Maybe we'll do a bonded retainer on the back of the teeth. Maybe we'll do a Thoreau retainer, which is like a removable kind of Essex that's kind of carved out for phase 1. Lots of different things we can do. I also love to use things like G appliances or MyoBrace or U-concept appliances just to maintain the transverse, just to make sure the airway is good. Kind of helps with the alignment too. Lots of things you can do for your phase 1 to phase 2 transition retention, although it's not always needed, so don't freak out. And then we just wait for all the teeth to come in, the 3s, the 4s, the 5s, and the 7s. And once they're all in fully, we might do a really limited phase 2. Most of the time, it's more of a cosmetic thing. Although we can't make any promises. I can't control how the canines and the premolars are come down. They could come down funky. Weird things can happen, right? It could be more complicated than expected. But the goal is to take the hard stuff, do it when the kid is young and compliant and wants the braces and wants all the funky appliances and things like that. Because I've never had a 7, 8, or 9-year-old who doesn't want all this cool stuff. They think it's the coolest thing ever. They're super compliant. They're excited to come to their appointments. In general, their hygiene is pretty good, not always. But that's something the parents should be able to control. Teenagers, 14, 15, 16, forget it. They don't want to be there. They're way too busy by then, to make these kind of complicated appointments. They're terrible at their hygiene. They're very unhappy about being at the orthodontist, and they're very self-conscious. And it's just a terrible time to have things on your teeth, just in terms of psychosocial behavior. So it just really makes more sense to do things in phase 1. Now, why do a lot of parents not do phase 1? Well, and even a lot of orthodontists don't do phase 1, which blows my mind. So from the parent's perspective, since I am a parent and I am an orthodontist, I can tell you. So let's talk about the orthodontics perspective. When I was trained in residency, we did very little phase 1. I mean, like 5% of our cases were phase 1. It was almost all comprehensive, older teens. Almost no adults either, 20 years ago. 13, 14, 15, 16, basically, was the ages we mostly had. And I already knew that was a difficult age because I had lots of siblings, But that's how we did things. And the goal was, let's try to save the patients as much money as possible. Just do it all in one go. Why is that not good? Well, again, I really want you to watch those other intercepted videos first. But remember, if you have major bite issues that require growth modification or expansion or MA, growing an upper jaw, stimulating a lower jaw to grow, fixing vertical, it is much, much easier. And sometimes not even possible to do. Much, much easier to do while the kid is still growing, before they finish puberty, before they hit their max growth spurt. In addition, sometimes it's impossible to do it if they're done growing. You just don't get a good outcome because there's no, the osteoclast, the osteoblast, the potential of growth is not there. Just for a simple crowding case, yeah, it's probably not a big deal. But for anything else more complicated where you need growth modification, we need to be able to harness the growth, okay? Not usually a huge deal in boys, at 13, 14, 15, because they're often still growing. Most of the time they are. But girls, some girls are done growing at 8, 9, 10. Actually, lots of girls are done growing by 8, 9, 10. You may not know. And this, if you're a parent, you know this. In a generation, it's just shifted. Even girls getting their first menstrual period has gone from, in the 50s, was 14 and a half. I think in the 80s was about 12 or 12 and a half, 13. And now in the 2020s, it's like 11, 10. Okay, it's much, much younger. And I have a teenage daughter, and I can tell you that is definitely a thing. I was blown away at some of these girls in 3rd and 4th grade. They're like full grown in 3rd and 4th grade, like 5'5", crazy. And these boys are tiny, So that is why we have to get the phase 1 done, especially in girls. But you need to be very cognizant about the patient's growth. It's not always having to do with height, right? You could have someone who's just fundamentally shorter. So you can't just look at the height and say, oh, they're not that tall. There's a lot of questions you have to ask. Boys, it's pretty apparent when they're going through their growth spurt. We've got stubble and mustaches, and by 4 o'clock, they're coming in your office. You're going to see it. You're going to hear voice changes and see Adam's apples, and it's nothing embarrassing, right? I ask questions about shoe size. Are your feet still growing? Are you shaving regularly? Usually I can just tell. So I know when the boy is pretty much done, but girls, you're not going to know. And it's also a very embarrassing topic, especially at an 8, 9, 10-year-old. And I can tell you as a parent, so many times we get these questions on health questionnaires and we go to certain offices and stuff. And am I fully honest? I am, because I understand the why behind it. But so many parents aren't honest. And plus, you could have dad fill it out. Dad has no idea. He just checked a no, 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 no. So it's really important that we get the full answer on that. Because if they're saying patient's still growing, hasn't had their period, hasn't started puberty, and they have, and you're just assuming it's okay to wait, you could really screw up this case. It's a huge deal. And so often we just gloss over it. So I really want you to understand the why behind that, and why almost every girl should have a phase 1 if they have a growth modification issue, if they have a severe issue in dentistry. And you need to, and that's the issue, is that so not often, parents are bringing their kids over when we want to, 6 and 7. Even waiting at 8 can be too late. We got to get them over to the orthodontist, or you in your practice as a pediatric dentist or a general dentist can do this in your practice, because you got these kids funneling in and out. And it always is so much harder for you to bounce the kid from your practice to ortho. I mean, you tell them to go, they don't go because they don't understand the why. They're like, she only has 8 teeth in. We don't need to go to orthodontist. They're just trying to take our money. Well, no, that's actually not true. So having been on the flip side of it, being an orthodontist and having kids coming in at 13, 14, 15 and saying, oh, shoot, we really can't fix this well. Why didn't you come in at 7 or 8, And they go, nobody told us. And this happens so often. I mean, like multiple times a day, parents in tears, kids in tears because now we have to pull out teeth, or now we have impacted canines, or now we need a jaw surgery because somebody dropped the ball. That dropping the ball is you, the primary care dentist. And yeah, you can lightly refer it. And so many times they said, yeah, the doctor told me to go, but I didn't understand why I needed to go. So I need all of you, all you general dentists and pediatric dentists, to understand the why. And if you are not, this is the take-home moment, if you are not doing phase 1 treatment in your practice, you have to make your patient go to ortho, and you have to explain the why. And every time they come in, you need to put pressure on them that they need to go, they need to go, they need to go. That is standard of care. You need to explain issues like this to the patient. And if you can't, you need to make them go to the specialist, okay? Which is why I think it's better that you all are offering it, because the problem is so few orthodontists still believe this. I mean, in their mind, they think it's okay, that we're waiting and that we're getting a subpar result. And it just blows my mind because it's just always so much better to do phase 1, phase 2. Anyways, okay, so that's one issue. Now let's address the cost issue. People think that you're paying twice, and you really don't necessarily, because if the pricing structure is correct, it really should be half and half. I mean, a little bit more. My phase 1 really depends on what am I doing. Am I throwing on braces and doing appliances? Am I only doing appliances? Am I only doing 4 braces? I mean, it really depends on what we're doing. Are we doing Invisalign with MA? Well, that's going to be a little bit more because my lab fee is $1,300. Am I doing retainers? Am I not doing retainers? So phase 1 pricing is somewhere around $2,000 to $4,000 for me normally, depending on what it is. And of course, if you are using insurance, it's going to be a fixed price. Sometimes it's very low. Things to look into. And then phase 2, again, I mean, I'm not even going to, sometimes they'll bundle phase 1 and phase 2 into one price, and that's really up to you if you want to do that, because you really don't know what the phase 2 is going to be, and you don't know if they move away, it gets messy. I don't prefer to do that unless, I know they're going to be committed to staying where they are. But phase 2 pricing, again, it's going to depend, because what if everything comes in pretty straight? I mean, I can tell you the story about my own son. We did some phase 1 at age 8. We did a little bit of growth modification, worked on his gummy smile, worked on his vertical, worked on his AP. Super easy with just an appliance. And now at 16, I mean, his teeth are like 99% straight. I didn't have to do a phase 2. We never did aligners. We never did braces. And I can tell you, if you look at his pictures, and I of course didn't take a full set of pictures at age 8 because, he's my phase 1 patient and it's my kid. So we just didn't take records. But I mean, now I wish I had, because it's just so obvious. I mean, his bite is great. He has maybe like a millimeter of crowding on the lower incisors, a millimeter 2, and a millimeter on number 7 right here. It's super minor. I can see it, because I'm an orthodontist, and I'm like, let's just do we just need 5 to 8 aligners here to make this perfect, Evan. And he's like, no, I don't care. I don't want to deal with it. And he's an athlete. He's like, I don't wear that. I don't want to wear that crap. I'm fine with it. Nobody notices but you, Mom. It looks great. They all think I had braces. So, I mean, yeah, it happens that sometimes you don't need. Whereas my daughter, we did expanders, worked on vertical, worked on AP, worked on transverse at 8, and she had an impacted canine still, and we did everything we were supposed to do, but it was, instead of having 2 impacted canines, which could have potentially happened, we only had 1, but it still happened, so we did need a full set of phase 2, and it happens, right? We can't always control that, and we did everything right, but it would have been so much worse had we not done phase 1, I can tell you that. So that's the why behind it. The pricing really shouldn't be a big difference. And like I said, so often you don't even need phase 2, or it's so minor they can just wait till they're adults, or you could just do a few easy express aligners. It shouldn't even be the full price. So anyways, okay, so that's everything you need to know about that. Now let's go into the whole phase 1 braces and how you do it, because so many times you guys are getting confusing. So first step in phase 1 braces is always to align and level. All different ways you can do it. Now this makes no sense to me. Some of these are stock pictures because sometimes I don't have good pictures to show. But I just like to show what people are doing and how I disagree with it. Now, first of all, some of these brackets are not even on correctly. Terrible placement. And their wire isn't even engaged. Your wire must be fully in the slot to work. So this makes 0 sense to me here. They should be figure 8ing it. But anyways, this is not going to get straight because I've got canines here. And this makes no sense because you really shouldn't even be putting the braces on until you've created the space to straighten them. And I don't mean just extracting teeth, because if you extract these baby teeth only without creating jaw space, all you're gonna do is block out the space for the lower threes, and then they're gonna be impacted. So that makes no sense. So what you'd need to do here is either do some type of lower expander like a Williams or a Flea to expand the arches. In order, of course, to do that, you're gonna have to do an upper one too. Or you could, there you can bond the baby teeth like they're doing here. People do put braces on baby teeth, which helps to at least tip them out, and expand the arches that way. Not my favorite way of doing it. It really doesn't make a lot of sense. And then later you could take the baby teeth out here too. But this makes no sense, right? Okay, you guys get the idea. Here, they're waiting for these teeth to come in, and they're using these as anchorage. You can do this, and that's fine. The goal here, obviously, is to quickly fix that anterior crossbite and get that tooth out of trauma. That makes sense to me. I'm fine with that, as long as these teeth are not going to become loose during treatment. That's the main thing if you're going to use them for anchors. Obviously, they're just trying to jump this quickly. These are probably not going to fall down until these come out. So as soon as they jump this, I'd probably put a bonded retainer behind here. Cut this off, wait for these to drop down. Once these drop down, then or maybe I would just leave it like this and just tie it really tight, wait for these to come down, because these are probably going to need braces too, because they look like they're going to come into crossbite. But anyways, so this is the align and level stage, right? First, you need to make the arches the right size, do what you need to do to fix overjet, negative overjet, underbite, everything like that, fix the jaws. Then you can go ahead and throw a few brackets on and fix any other issues that are happening. Once you've done that, and assuming you've done some arch expansion and made some spaces, you might need to do some power chain. I didn't have a very good photo of how the power chain goes, but just a friendly reminder, anytime you're doing power chain in a phase 1 case, you do not ever power chain on a sectional wire. What do I mean by that? A sectional wire is a front wire only with a cinch, like you have here. And this is done right, the way they did this, or it could be like this to this. You don't ever power chain on a sectional wire. Your wire needs to go like this all the way to the back, anchored to the molars. A lot of times I'll go ahead and put brackets just on the E's, A and J, because I think it's so much easier than trying to bracket a 6, 3 and 14. And banding a 6 can be a nightmare too. Sometimes if it's an appliance, I'll band the E's, because they usually don't fall out till 12, right? So if this patient's 8, we should be fine to band the E's. I don't really care. So you need to have a big rectangular wire going to the back. I usually use 1825 nite tie. You can use steel if you would prefer to have it, but I always put the nite tie in first to help level. And then we're gonna go ahead and do our chain if we have spacing. Remember, chain always goes from mesial to mesial, unless you're all the way back to the 6s. So you're gonna have a link here on the mesial of 7, then 8, then 9, then the mesial of 10. Then you always put a single tie on the distal of 7. So single tie on the distal of the upper 2s, chain goes from mesial to mesial, lateral to lateral. Now, if you only have closed chain, or if there's a lot of spacing, you might need to leave extra links in between the chain, and that is totally fine. Or sometimes I'll put a link here on the mesial, link on the distal, link on the mesial, link on the mesial, link on the distal, link on the mesial, and a single on the distal. So you can do that. It's okay to leave extra links as needed. There should be some pull, but it shouldn't be enough to break a bracket or make the patient cry, okay? If it's making the patient cry and squirm, well, occasionally you have whiners. They should just bite down on a cotton roll. But it shouldn't be that bad where you're like worried the bracket is gonna break or you're sweating or breaking a sweat. It should just be a light pull. Really, really easy breezy. And the space will close. And then at the end, it should look like this, and then you're done. You can go ahead and do retention if that's what you desire, and that is the steps in phase 1 braces. All right, thanks so much. And just remember, whenever you have a long wire like this, unless it's super, super stiff, you will possibly need to put some tubing here or flame the ends before you put it in and then cinch it in the mouth. Or you can put a rubber tie on the back. All right, thanks so much.